Prashant, you may start now.
लोशन दिलेलं आम्हाला एक औषध दिले ॲलर्जीसाठी खोकल्याचं दिले आणि नाकाटाक.
Good afternoon, doctors. Welcome to this webinar on influenza and its prevention, sponsored by Hetero Healthcare. It's an innovative pharmaceutical company. The journey of Hetero Healthcare began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare is Asia's largest APIs manufacturer. We have Asia's largest API manufacturing at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Pioneering in quality and innovation, and Hetero Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antiviral, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which they received an award of Pharma Excellence in August 20 for COVID drugs. Today's webinar, we have got two speakers, Dr. Sampat Kedare and Dr. Keyur Mahajan. Welcome, Dr. Kedare. Welcome, Dr. Mahajan. Dr. Sampat Kedare is MBBS DCH Boston, ex-medical superintendent Government of Maharashtra, ex-member Secretary State Rotaviral Committee, consultant pediatrician, Kedare Hospital, Bal Rugnalaya, Chakan. Welcome, Dr. Kedare. Dr. Keyur Mahajan, MBBS DNB, Pediatrics Pune. Sir is diploma in pediatric infectious disease from Oxford, UK, and pediatric infectious disease consultant, Pune. Welcome, Dr. Keyur Mahajan, and with this, I hand over the session to both of you. Thank you. Dr. Keyur, you are starting. So you can start.
Hello,
Yes, sir.
am I audible?
Yes, sir.
Very good afternoon to all.
Good afternoon, sir.
At the outset, I would like to thank our hater team for giving us a special opportunity for on this special topic, influenza and use of oseltamivir in influenza. I thank you, the team, whole team, and I thank you all the participants for interactions and interactions. Thank you. Friends, today we have come here to discuss something about flu and its implications in routine activity, routine OPD. Friends, as you know, we as busy pediatricians, during such a rainy season, we do come across many viral illnesses in our routine OPD. Nearly in an busy OPD of 100 OPDs, nearly we come across about 20 to 25 patients in routine OPD of viral illnesses. But not only one single viral illness we are facing, but we are facing many influenza-like illnesses and many other illnesses also. So these are the challenges which we are facing in the monsoons, and what is their diagnosis. We like to go ahead in health-related challenges in the monsoons. For example, influenza-like illnesses, H1N1 infection, severe acute respiratory illness, and COVID-19 illnesses.
Sir,
Influenza.
Yes, see, screen is not visible. We can see only your presentation. Screen is not visible.
Screen is not visible.
No.
Can you
share karantu?
Okay. Yeah. Just a minute, please. Screen is not sharing, sir. Is it visible now?
No, sir, I cannot see. Others you can see?
Can you see the screen?
Yes, sir, it is seen now.
We can see only Dr.
Yes,
Kedare's
yes.
presentation.
Yes.
But I'm not able to see slides.
Can you see the slides now?
I'm unable to see. Can you see
So I can see.
slides?
Yes.
Okay.
Changing also.
Okay.
Can you see, please, again?
Yes, we can see the first slide, sir.
Okay.
Yes, I can see now.
Okay. Got it now?
Yeah.
Okay. Take it. So what the healthcare challenges what we face in monsoon seasons and their diagnosis? So what are the healthcare challenges we routinely face in routine OPDs, like influenza-like illnesses, H1N1, SARI, severe acute respiratory illnesses, and COVID-19. HLI, influenza-like illnesses, which are those infections that we may face routine OPD with respiratory syncytial virus illnesses, number 1, metapneumovirus, number 2, influenza, parainfluenza virus, and so many other arbovirus, picornovirus, and all other illnesses also. So what is important for us is that we in routine OPD in this monsoon season, we do come across many cases of influenza illnesses. So what is the dynamics of occurrence of influenza in relation to seasonal variations? This is the special peculiarity of this virus, that this virus has got predilection which are with increasing number of cases during this monsoon season. But not only in monsoon, it is for the whole year, this illness is sporadically in various areas. So the influenza positivity started with the onset of monsoon and peaks during the post-monsoon months. This is very important. So what we are worried, what we should be cautious that in this season, we should be thinking this illness as a strong predictor for diagnosis. This is the overall influenza illness in India. This slide is slightly of old period, but what we have to implicate is that during the before pre-COVID season period, there were drastic increase in number of cases. But during the COVID period, because of special COVID preventive protocols, there was a drastic reduction in the number of cases of influenza. But no sooner the COVID pandemic was over, now again there is increased number of cases of influenza. What we can see that during the 2019, we do come across many cases, out of which there are many number of deaths are also more. So this is very important for us. So in this current scenario, as we discussed, in the 2024, number of cases are slightly increasing and deaths are also on increasing verge. So what is most important for us is that we should take this illness as a top priority. So in the seasonal period, so that we should not miss the cases. So how does it present? Influenza is one of the most common infectious diseases caused by influenza virus. It is highly contagious airborne disease which occurs in seasonal epidemics and manifests as an acute febrile illness. So during each and every acute febrile illness, we should definitely not forget that it could be influenza-like illness. So it can cause mild to severe illness, and it has got serious outcome of flu infection, which may make us to hospitalize the patient, or sometimes the patient may have to face some death. This is very important for us. So what are the types of influenza viruses? Friends, as you know, there are 4 types of influenza viruses: influenza A, B, C, and D. Out of which we human beings face specifically influenza A and to many extent B also. In C and C virus is infection is mild comparatively, and D is not seen in humans; it is seen only in animals. In influenza A, the peculiarity is that it has got frequent outcomes, epidemics due to minor antigen variations, and periodic pandemics due to major antigen variations. This is the peculiarity of this influenza virus, which make us to be aware and to be prepared to face the influenza A epidemics in routine period, because of there is internal mutation of the virus, and that changes every yearly. That makes us to prepare newer and newer vaccines and every yearly because of antigen drift, and there is internal mutation. Now, how does the influenza virus transfers? Transfers. Friends, as you know, it can be transmitted properly by majority wise with flu, that can be sent to other by nearly about 6 feet away from this distance. Those patients who are having flu illness enough, these are the culprits. They can transmit. This is very on top priority. Number 2, the flu viruses are spread mainly by droplets made when the people with flu cough or sneeze or talk. So this is very important for us. Number 3, the droplets can land on the mouth or nose of the people who are near, or possibly by the inhale into the lungs. People should stay away from the affected person and stay home if sick. It is also important to wash their hands before and after use with soap and water. If soap and water is not available, we should use hand sanitizers as a routine mark. Number 4, most healthy adults may be able to infect others beginning 1 day prior, or after the development of symptoms up to 5 to 7 days after becoming sick. This is very different. This is a very peculiar thing about the adults. Adults may not have classical full-blown disease, but they can transmit the infection to the others. Children may pass the virus for longer than 7 days because children have got high virulence, and that's why they share the virus for a prolonged period, not only 7 days, for more than 7 days also. So what is important for us is that we have to break the chain of transmission. So what is the symptomatic differentiation of influenza-like illness, H1N1 infection, severe acute respiratory illness, and COVID-19? Since as you see this tabulated form, where all viral illnesses having somehow to major extent all same complaints, but fever, myalgia, cough, and lack of energy or sore throat, they are common in all type of infections. Breathlessness initially may or may not be, but it is at the disease progress, there may be increase in breathlessness in H1N1, SARI, or COVID-19. There is loss of smell or lot of taste in influenza-like illness, H1N1 infections, and severe acute respiratory illnesses. But in COVID, there is total loss of anosmia. Diarrhea is seen slightly common in slightly in COVID-19, but also in adenovirus patients, patient may come out with diarrhea and vomiting, as also some infants of influenza patients may have vomiting or diarrhea. So this is very important. In infants below the age of 2 years, the presentation may be slightly differ as compared to the adults, slightly post these things. The headache may or may not be present in below the age of 2 years, but those patients who can complain about headache, that may be common in slightly H1N1 infection or sometimes in COVID-19 also. In SARI or influenza-like illness, it may or may not be there, or in severe acute respiratory illnesses, it may or may not be there. So what are the emerging warning signs of the flu and sicknesses? Specifically in children's, that too below the age of 2 years, and that too the children's who are having some comorbid situations, the children who are having underlying heart disease, underlying respiratory disease, underlying asthma or chronic obstructive lung disease, or failure to thrive, or some renal hepatic comorbid situations. These are the children who are likely to suffer. Or not all the children come with full-blown influenza disease, but the disease is more vulnerable and more toxic in those patients who are at risk. So what I have mentioned, that the at-risk kids are more susceptible to face the infection and the complications. What are the complications? How do they present? They present in the way the fast breathing with trouble breathing. There is cyanosis. Child is not able to drink fluids. Child is not able to walk, or child is not able to interact, or being so irritable that the child does not want to be held. These are the flu-like symptoms which may improve, but return then with fewer or worse cough. Sometimes this patient may come with pneumonia. Sometimes some of these patients may come with otitis media, and some of the patients may come with some complications of the influenza. As against in case of adults, all adults who don't come with full-blown disease. Many times many adults who are having good immunity, they overcome the disease illness in a very smoother way with best recovery. But the adults who are having comorbid situations in the form of chronic obstructive lung disease, tuberculosis, or some other patients who are undergoing some anti-cancer treatment, or patients are having HIV or AIDS or immunocompromised status, or those patients of cardiac or diabetic illnesses, pregnancy, these are the patients who are more susceptible to the complications of the disease. How do they present? They present with dyspnea, shortness of breath, pain or pressure on the chest or abdomen, sudden dizziness, confusion, sudden or severe or persistent vomiting, or flu-like illness that does improve, but then return with some progression of disease or worsening of cough. In addition to all these above signs, get medical help right away for any infant or child below the age of 2 years with the signs of not able to eat, unable to take breathing, there is dyspnea or difficult breathing, or there is no tears, or significantly fewer wet diapers than normal. So what are the complications which we face routinely? Routinely, we face the complications which are specifically in the high-risk age group, as we discussed. The complications start from head to toe. In the neurologically complications, we may come across encephalitis, encephalomyelitis, Ray's syndrome, or acute transomyelitis, or sometimes we may come with death also. Number 2, in case of respiratory tract, we do come across dry cough, prolonging cough, pneumonia, sometimes some pneumonic effusion, or secondary bacterial infection, post-viral infections, and that patient land into some distress and cachremia, or sometimes patient may need admission also. Number 3, bronchitis, as we discussed about it. Bronchitis, the peculiarity of bronchitis is that the dry cough continues for a prolonged period, even though the symptoms are reduced, the dry cough persists for 3 to 4 weeks. Number 4, as we discussed, this otitis media. This is one of the nearly 25 to 30 patients of influenza who are not appropriately treated before the full-blown disease. They develop otitis media. This is a very peculiarity of this disease. Number 4, there is worsening of the existing disease like asthma or COPD. As we discussed, those patients who are high risk, these are the influenza-like illnesses. They worsen the previous existing disease, and that may land us stable in patient need indoor admission and the indoor management accordingly. ARDS, acute respiratory distress syndrome, one of the very present important feature. Many times patient don't come to us as earlier within a short period. Patient come to XYZ, number 2, some other general practitioner, thirdly to some other pediatrician. Then if the patient doesn't feel better, patient to approach to us. In these cases, situations with the patient, the disease has been progressed, and the progression of disease, patient lands to ARDS. So these are the very important complications. And along with that, those patients having underlying disease, underlying other diseases, they are worsened, and the patient may land with death. This is very important. So don't take the things lightly. Be vigilant, be alert, and be cautious. If see the epidemiological trend of the disease, condition of the child, presenting illnesses, presenting features, and think strongly whether it could be influenza. Sorry. So how do we manage such kids? Friends, as you know, the earlier we diagnose the patient, the treatment start. Usually the treatment is that we have to think of preventive protocol. Number 1, we should suspect that if the patient is exposed to some family member, for example, children healthcare settings, for example, in children nursing homes, where there is overcrowding of the kids, and the kids, one of the kids gets infected, yet transmitted disease to the others. So these are the sources. Number 2, with the caretaker, mother or grandmother, or the caretaker is suffering from illness. These are the kids these are the culprits who transmit the disease, and the disease progresses. Thirdly, how do they treat the patients? Most important thing that we have to take the preventive protocol. What use of mask, use of appropriate sanitation, use of bed rest, increased fluid consumption. Sometimes if the mild cough is there, we can use cough suppressant. But in case of cough, if the cough worsens, or if there is associated with tachypnea, tachycardia, distress, interpersonal indrawing, and something like that, we should suspect that could be having progression of the lower respiratory tract disease. It could be having pneumonia. We have to treat the pneumonia as such. Then we have to go ahead. Treat with antibiotics, analgesics, and use NSAID as per the situations. But friends, as we know, in grade 1, the A and B or C, there are grades as per WHO recommendations. In A, influenza A, like in the A grade, these patients can be treated on OPD basis, with the follow-up on the OPD with special features of going in progression. We tell the parents to see watchful for the disease of progression, and make them to attend in the OPD in a regular basis in a proper way, so that we can observe the patients for complications, and we should be anticipated for the management of complications. Most patients with influenza recover in 3 days. However, myalgia may persist for more weeks. The severe cases may require intravenous hydration, or severe cases may require supportive treatment. The treatment is not only, this is only on OPD basis, we can say, but not all patients which we as a pediatrician, we see many patients with complications, with associated illnesses. So not only treating the patient on OPD basis, we should always see for the other associated illnesses, treat the associated illnesses appropriately, properly, cautiously, and those patients who need antivirals specifically, we should start without delay. This is very important for us. What is the treatment for the influenza disease? The most important thing is that the earlier we diagnose the patient, the diagnosis, as we discussed, it depends only on the epidemiological trend of the disease, high index of suspicion, presenting features of the disease of the patient, and with that accordingly we can think of putting the patient on high risk antivirals specifically to the high risk cataract class. So which are the drugs which are specifically used? We select specifically the drug which is called as oseltamivir, which is neuroaminase inhibitor, which blocks the neuroaminase viral. It blocks the viral neuroaminase enzyme, which is critical in releasing the virion from the infected host cells. These drugs are active against influenza A and B. These are the two illnesses that for which we are worried. So which are the drugs? The drugs are oseltamivir and zamivir. Amanitin's usually they have proved that there is high resistance, and that makes us not to use these drugs. So how this oseltamivir has to be used? Friends, as you know, it is one of the very wonder drug, which is, if it is started as earlier within a period of 48 hours, it is really helpful, and it arrests the progression of disease, thereby halting the progress, and it improves the recovery as fast as possible, and patient doesn't feel that the patient was ill totally. So how does it act? It is a potent selective inhibitor of the neuroaminase enzyme of the influenza A, virus A and B. It is a good prodrug which is converted into active form, that is oseltamivir carboxylate in the liver. It inhibits the influenza virus replication and pathogenicity. It prevents the further spread of disease. It is effective against all strains of influenza A and B. So this is the diagrammatic schematic representation of the diagram of the virus, showing how does it act and how does the neuroaminase inhibitor act. So as you saw, friends, you know, this drug, it halts the virus replication because of it has got having the action of as a neuroaminase inhibitor. It is the first oral drug. It is approved in the more than 100 countries. If it is started within 48 hours of the illness, friends, in this case, I would like to underline that we don't see the patient within 48 hours, because the patient is being seen by other general practitioners or other colleague or anybody, which makes us that patient, we see the patient on 3rd, 3rd day, sometimes 4th day, but the late, even though with the patient comes to late to us, we don't wait for the drugs to start, because rather than not giving the drug, it has been proved that drug is so helpful, even though it is slightly late given. So what are the doses? Friends, this is a tabulated form of oseltamivir doses, which is shown in here. Our textbook of IIP and textbook of Nelson textbook of medicine also shows all these things. These are standard dose schedule. We know will not go in detail, but the thing is that it is very important that we should start in appropriate doses for appropriate period, and that we should watch for any other side effects of the drug if at all is there. It has been observed that it has been well tolerated by all, including the infants till the adults, and it has been a wonder drug which is helpful to have a faster recovery and with least morbidity and zero mortality. I would like to add about the chemoprophylaxis, to whom it is to be given. It is to be given those kids which have been treated, but the family members may not be coming to us or may not be having full-blown disease, but they have chances of transmitting the disease to others. So these are the main patients, then main members, family members, other kids or other supportive system. They should be treated with chemoprophylaxis for at least a period of nearly, in outbreak situation, we can give up to 6 weeks, specifically in immunocompromised situations. I would like to add that in case of children care home settings, we should always give oseltamivir in a very proper way, prophylaxis in proper way. These are the clinical trials which we can see is that how it has been helpful. This is one study has been done. It's a 50-year-old man, a farmer by occupation of India, with no underlying condition was reported to us in a tertiary care institution in Srinagar. Patient had complained with low-grade fever, sore throat, myalgia for 7 days. He denied any history of chest pain, breathlessness, orthopnea, vomiting, and diarrhea. Before referral, he had received antibiotics in the form of ceftriaxone and levofloxacin without any improvement. So what was revealed on examination? His vitals were tachycardia was there, BP was 110/70, temperature was 100. Chest examination revealed that there was bronchial breathing associated with bilateral pores crepes. His CPK was and LDH were higher. There were on X-ray, it was showing that there was mid-zone interstitial pneumonitis with where we had to take a nasopharyngeal swab, which was revealed that their PCR was positive for H1N1 infection. CRP also low. Cardiovascular, abdominal, central nervous system were normal. Lab was normal, along with normal WS count. LFTs were also normal. So this is the X-ray which shows that there was bilateral infiltrates. So which showing that there is classical bilateral mid-zone infiltrates. So what was given? So patient was put on, when the patient was told that it is a patient of H1N1 infection, the patient was immediately put on oseltamivir for 75 mg BID for 5 days, along with paracetamol with oral hydration and hand wash. Patient showed marked improvement in his symptoms and with progressive decrease in the CPK and LDH and subsidence of infiltrates on chest X-ray as compared with the previous X-ray. Friends, here I would like to underline this that the patient had been treated at XYZ place, patient come late, patient we take the X-ray, that means the patient, the disease was progressed. But after having confirmed, and even though we have started oseltamivir slightly late, it has given very good response. That means what? Even though the patient, we do come back to the patient lately, we don't hesitate the patient to start on this tablet oseltamivir in appropriate dose for appropriate period. This is very important. As you know, friends, oseltamivir treatment with influenza illness reduces the LRTs, antibiotic use, and hospitalization. This is a study which shows that the study was done in nearly 4,000 subjects, which were having an ILI, influenza-like illnesses, and 10 were placebo controlled, which showed that patient with influenza oseltamivir treatment reduced the complications and reduced the severity of pneumonia and further complications. This is a tabulated form of probability of the occurrence of pneumonia, severe pneumonia, and use of oseltamivir. The probability of severity of pneumonia and probability of severe pneumonia increase gradually with the time of symptoms of the onset of oseltamivir admission. But earlier initiation of oseltamivir administration after the symptom onset significantly reduced the occurrence and severity of pneumonia and shortened the hospitalization due to pandemic of 2009. This was a study done during 2009. What is important for us is that even when administered 48 hours after the symptom onset, oseltamivir showed considerable potential for reducing the pneumonia. That's why we have already discussed that even though we are slightly late to start, we should not deny to put out the patient on the antivirals. Again, what I would like to say is that patients with shorter time of oseltamivir admission were discharged earlier in the hospital. That means patients' hospital stays, prolonged hospital stay is minimized, and patient fast recovery makes us to discharge the patient as early as possible. That also halts the burden, economic burden on the parents and the relatives accordingly. This is a drug showing azithromycin combination in the therapies reduce the secondary bacterial infections. But in this study, azithromycin we cannot start without appropriate need or without a dire need, because in a recent trend of national antibiotic therapy, we should always think 10 times whether the patient really need to put on and azithromycin before the patient needs use of antibiotics. So what are the guideline recommendations? WHO recommends that empirical therapy is strongly to be recommended. This means what? We should see that if there is seasonal trend, number one, if the kids are the family history of some illness, influenza-like illness is there. Number three, those kids who are high risk kids are those patients about the age of 65 years or pregnant women having comorbid situations. We should not delay the empirical treatment to start. Even though our lab confirmation is not there, even though lab reports are sometimes maybe false negative, or sometimes they may be false positive. The false negative test also says that we can start in oseltamivir appropriately in appropriate doses. But only thing what we need is that strong index of suspicion and classical indicators for starting the drugs. Treatment should be started as possible, as soon as possible. Laboratory confirmation of virus infection is not necessary for initiation of treatment. Negative laboratory test does not exclude diagnosis of PN and percent of disease. And if the patient have high-risk individuals have been exposed to patients with influenza, consider presumptive treatment with oseltamivir. So early and empirical treatment, supportive treatment and monitoring. Give empirical treatment, antibiotic treatment to treat all pathogens causing SARI. This is very important. Those patients who are having superadded bacterial infections, secondary bacterial infections along with after viral illnesses, those patients who are already having some comorbid situations, these are the only clients where we can think of giving antimicrobials. Empirical antibiotic therapy should be based on clinical diagnosis, that is CAP, community acquired pneumonia, healthcare associated pneumonia, and infection was acquired in healthcare settings or sepsis. So this is very important for us. The empirical therapy includes neuroaminoase inhibitor for the treatment of influenza when there is local circulation of or other risk factors, including travel history, exposure to animal influenza viruses. The adults with CAP who test positive should the treatment regime include antiviral therapy. What are the recommendations for WHO? WHO recommends that anti-influenza treatment with oseltamivir be prescribed for adults with CAP, community acquired pneumonia, who are positive for influenza in the IPD settings, independent of duration of illness, before diagnosis. This is a strong illness. This is a strong indicator, recommendation. So what is important for us that when the patient is enrolled with us with having associated comorbid situations in any form, we should always put the patient on oral oseltamivir. Those patients who can't be put on oral oseltamivir, we can think of intranasal zamavirin or IV perimivir. It's very important. Several observational studies suggest that the treatment with oseltamivir is associated with reduced risk of death in patients with hospitalized with CAP who test for positive influenza virus. This is very important. So treatment with within 2 days of symptoms of onset or hospitalization may result in the best outcome. So this is what is the crux, and this is what is to be message to be taken by all, that if the earlier we start, in appropriate doses for appropriate period, the best are the results, and the least are the complications, and least is the morbidity or mortality. So in summary, proper diagnosis and early treatment can prevent flu complications. So what are the complications? As you know, we know, friends, all these complications we discussed. In case of CNS infections, we like to repeat it. Encephalitis, encephalomyelitis, acute transmittal myelitis, Ray's syndrome. Though in those kids who are already having some comorbid cardiac situations, who are put on aspirin, these are patients sometimes they develop Ray's syndrome. In case of lower respiratory tract bronchitis, pneumonitis, or sometimes there is secondary bacterial infection causing sepsis also. In case of cardiac, there may be toxic viral myocarditis. These are the complications. And in case of liver or renal complications are also there. In case of renal problems, the patient may go in renal failure also. Though these are all complications which can be minimized and can be curtailed to a great extent, and it helps to decrease morbidity and mortality by using proper diagnosis and by using earlier initiation of oseltamivir. So empirical use of oseltamivir reduces the low respiratory infection complications, hospitalization, and use. WHO and American Thoracic Society recommends that empirical use of oseltamivir is not at all a contraindication. We should always take it on top priority. So friends, with this, we have nearly discussed what is influenza, what are the types, how does it present, what are the clinical epidemiological trends, how does the clinical child clinically present, what are the possible complications and how they can be managed, and most important thing is that the vaccination. But I would like to elaborate something about vaccination. Because of invention of vaccine and because of the peculiarity of the influenza vaccine, there is antigen stripped and internal mutation. The virus has got tendency to get changed, get internally mutated each and every yearly. So we have to we have to invent the vaccine yearly, and it gives a very good. It is very good way of prevention of further disease and decreasing the episodes of the disease. What is important for us is that we should always vaccinate the child up to from the age of 6 months to nearly to the age of 18 years. What is recommended is that unless and until there is contraindication for the vaccination. What are the contraindications for the vaccination? The only contraindication is that if the patient is seriously ill for a temporary being. Number two, those patients who are on steroids, those patients should not be vaccinated at least period of 1 month to maximum period of 3 months, and that too the further consultation of our in our setting we should think and we should decide about it. Number three, the vaccination is really helpful for us. That has been proved that it's helped to nearly give 50 to 60% coverage in that kids. So further episodes of acute illnesses due to influenza, they are being minimized, and we have been. I'm sure that many of us we having been using the vaccination during OPD that has really helped us to curtail the complications caused by the influenza virus, and many times the influenza virus, the illness can be treated on OPD basis in a proper way because of invention of vaccine, and the vaccine has really given us a beauty. And yeah, I am happy that should say that just because of vaccination, we are slightly in a hope that even though the patient suffers from influenza-like illness, patient doesn't come with complications and patient don't develop complications. So with this, I think I will not take more time because my learner colleague is going to speak up next thing. I would like to thank to the organizer. I would like to thank to the participants and listeners who have for my patient listening. And I again thank you, Samruddhi, and all team for giving their proper time to interact with me in the proper way.
Thank you,
Thank
sir.
you. Thank you, madam. Thank you. Thank you, sir. Take care, sir.
Yes.
Wish you. I'd like to hand over to you for further discussions.
Yes.
Thank you, sir.
Welcome to Keyur.
Is my screen visible?
Yes, sir.
Yes.
Yes. So I will. Okay, so thank you, Kedare sir. Thank you for such a wonderful epidemiology, clinical features, and guidelines and management part in influenza, and also covering the vaccination part. So continuing with that, we have discussed there are 4 types of influenza viruses: A, B, C, D, and A and B are significant for us. A are further classified, as we have discussed, into subtypes according to the combination of proteins. So it depends on the hemagglutinin surface protein and neuraminidase. So it is labeled as H1N1, H3N2, H2N3, like that. So currently circulating human subtype is H1N1 and H3N2. So these are the current circulating strains included in a vaccine. Influenza A, it is H1N1 Victoria strain. It is A again second strain, H3N2 is included, Croatia strain. Influenza B, there are lineages, there are no strains, but there are 2 lineages, Victoria lineage and Yamagata lineage. Influenza B Victoria lineage is included, and 4th is Yamagata lineage. Now, WHO has also recommended the transition from quadrivalent to trivalent vaccine for 2025-26 season, as the Yamagata lineage has not been detected since March 2020. The activity has not been detected and is no longer considered a public health threat. But still, in India, we are having quadrivalent vaccine and we are using it. So, whatever vaccine available, we have to use it. Now, India usually falls in southern hemisphere, but the vaccine gets updated every 6 monthly, the new according to new strains for northern and southern hemisphere. But there are no strain changes right now. So whatever strains are currently are in vaccine are going to be there for next year also. So whichever latest vaccine is available, irrespective of southern or northern hemisphere, we should give it to our patient. And influenza C, as sir has told, it is mild and it is not public health important. Influenza D primarily affects cattle and not in humans. So we are worried only about influenza A and B. Now, whenever patient comes to our OPD, the usual dilemma is whether this is bacterial or viral pharyngitis. So the usually patient comes with cough, cold, fever, and some sore throat. So to differentiate between bacterial and viral, this figure might help somewhat. In bacterial, we can see red and swollen tonsils with some exudates. Exudates means whitish spots we can see. There will be throat redness, gray furry tongue, and swollen uvula. Viral also we will have red swollen tonsils, throat will be red, congested, but the exudates will not be there. So this is the somewhat picture what we see in bacterial pharyngitis and viral pharyngitis. In bacterial pharyngitis, we are mostly worried about streptococcal pharyngitis because this is the most common bacterial cause of pharyngitis. Other bacteria are also there, but what we are worried about is streptococcal pharyngitis, most common. And the second picture is viral pharyngitis. The treatment differs. We want to differentiate it because treatment differs. In streptococcal pharyngitis, we use amoxicillin for 10 days. In viral pharyngitis, it depends on severity whether we should use antivirals or not. So what are the current guidelines? Current guidelines say any patient who comes with flu-like symptoms should be screened at healthcare facility and should be differentiated according to the severity. And the severity will decide whether to treat, whether to investigate, whether to admit. So what are the categories they have broadly described? Category A, patients with mild fever plus cough, sore throat with or without body ache, headache, diarrhea, and vomiting will be categorized as category A. So this is the milder variety, what we see commonly in our OPDs. But mind well that whenever any patient comes with category A on day one with milder variety, they may progress to category B also. So whenever we are not prescribing anything and we are just giving symptomatic treatment, do not forget to ask them to come for follow-up if symptoms worsen the very next day or within 48 hours. These patients do not require oseltamivir, should be treated for the symptoms with bed rest, plenty of fluids, and paracetamol for fever. Of course, these patients should not be tested for H1N1. Most of the time, the disease is not severe enough to warrant antiviral and is self-limiting. Patients should confine themselves at home, avoid mixing up in public and high-risk family members. Usually, no laboratory testing is required for such patients. So these are the milder varieties. What second varieties we see in our OPD are category B patients. In addition to all the signs and symptoms mentioned under A, under category A, as we have discussed, that the patients may come with the diarrhea and vomiting also. So in influenza, like illness in pediatric patients, along with respiratory symptoms, GI symptoms are also common. So we should also keep that in mind. So in addition to the signs of mentioning category A, high-grade fever and severe sore throat. So if the fever is high-grade, severe sore throat, oral intake is poor, so then they land into category B. Also, the children who are high risk but still they are in category A also should be treated like category B. Who are at high risk? Okay, those who are having predisposing factors, pregnant women, elderly more than 65 years, then children who are having previous lung disease, heart disease, liver disease, kidney disease, blood disorder, diabetes, neurological disorder, cancers or immunosuppression, patients who are on long-term steroid therapy. So these patients, though they are in category A and you are suspecting influenza-like illness, then you should start with oral oseltamivir, oral antiviral therapy. In such patients, investigations may be sent on OPD basis. That depends on availability at your place, but after COVID, most of the places, most of the labs, even in peripheries, are equipped with RT-PCR test, and they're easily available. And the turnover time has also reduced to 1 day. So very next day you get results. So you can send, but don't wait for the reports or don't wait for the test to start antivirus. They should be started as soon as, preferably within 48 hours. As far as shown, some studies are there which have shown that if the antivirus are started within 48 hours, they are best useful. But still, IAP guidelines says we can start up to 72 hours also. Okay, this is for OPD based treatment. Okay, for indoor patient, the duration is different. Now the category C, in addition to the above signs and symptoms of category A and B, if the patient has one or more of the following, like breathlessness, chest pain, drowsiness, fall in blood pressure like hypotension, sputum mixed with blood, bluish distillation of milk, like hypoxia, then such patients with red flags like somnolence, high and persistent fever, inability to feed while convulsion, shortness of breath, difficulty in breathing, worsening of underlying chronic conditions, which are whatever predisposing conditions are there, pre-lying conditions. So these all patients should come into category C. They should be immediate hospitalized, started with antivirals and other supportive treatment accordingly, and the testing should be done. So in summary, category A, milder variety, home isolation, bed rest, plenty of fluids, paracetamol for fever. Category B, above plus antivirus, preferably within 48 hours. Testing may be done on OPD basis. And category C, testing immediately, hospital admission, antivirals, and other supportive treatment. So these are the broad guidelines for management of if any patient who comes with influenza-like illness. Now, as it has been discussed, there are various antivirals available: neuraminidase inhibitors, oseltamivir, zanamivir, peramivir, cap-dependent endonuclease inhibitors, baloxavir, and adamantine, amantadine, rimantadine. Now, the adamantines, they are not used nowadays because they are only active against influenza A, not against B, and that too the currently not recommended because of widespread antiviral resistance in circulating influenza A viruses. Then cap dependent endonuclease inhibitor oral baloxavir, but it is not approved in India yet. Okay, it is a potent selective inhibitor of cap dependent endonucleases. It has been approved over 12 years in US FDA as a single dose oral treatment, and but not approved in India yet, so we are not using it. Again, peramivir, it is IV use approved by FDA for the treatment of acute uncomplicated influenza within 2 days of illness onset in people 6 months and older. IV, it is administered IV, dose varies according to age, and the efficacy based on clinical trial versus placebo is predominant against influenza virus type A and very limited type B. Okay, but the enrolled patients with type B were very low. So there are no much data available for the use of peramivir in chemoprophylaxis also. So it has also got some limited use. Zanamivir, it is approved for treatment of flu in children 7 years or older. Not recommended for use in children with underlying respiratory diseases, including those with asthma and chronic lung diseases. And it can be given in the inhaled form via special inhaler called as disc inhaler. So the use of zanamivir is also not that common in our country. What we use commonly and easily available is oseltamivir. It is neuraminidase inhibitor, most widely used and abused antiviral. So these are the dosages charts. Sir has already shown this chart, but this is one different from the IPIT standard treatment guidelines. And here directly doses are given according to weight slots. Okay, so just see in the your child fits in which weight slot and give that dose. Okay, so for example, if it is less than 3 months, 12 milligram per dose. Then for treatment, the same dose comes as a twice a day, and for prophylaxis, same dose comes as a once a day. Okay, prophylaxis is approved about 3 months of age only, not below 3 months of age. So prophylaxis is approved more than 3 months of age. Dose is once a day, and duration is for 7 days. Some guidelines extend it to the 10 days also. For treatment, the dose oseltamivir can be started at any age. There is no bar for starting oseltamivir. age bar. It can be used in neonates, it can be used in infants, it can be used in elderly, all age groups. The dose is twice a day and duration is 5 days. Adverse reactions of oseltamivir is generally well tolerated. There are some GI side effects, may increase with increasing doses, but we don't use that much high doses in pediatric population. And it may occasionally cause other side effects, bronchitis, insomnia, vertigo, abdominal pain, epistaxis, but they are very rare. So in all, the oseltamivir drug is very well tolerated by pediatric population. Now, these are the guidelines for the use of oseltamivir as a prophylaxis. IDSA guidelines is in institutional outbreak settings, it can be used continued for 14 days or 7 days after the onset of symptoms of the last person infected, whichever is longer. And then this is the second recommendation. They have said that those whose onset of symptoms occurred more than 48 hours before presentation. If the child comes late, little bit late, like 72 hours, on third day or fourth day, so what we should do? Then with persisting moderate and severe illness, still we can give oseltamivir. There still can be, the benefit is there, but only thing is it has not been studied. Step-10 efficacy has not been evaluated prospectively. But still, as we know that oseltamivir is much safer drug, so IDSA CDC says that you can use in moderate to severe illnesses even though the duration of 48 hours, a window of 48 hours has been passed. Now, these are the few cases we will be discussing. This is case 1. A 2-year-old child present with sudden onset of fever, 104, cough and some lethargy. Examination reveals red throat, clear nasal discharge, scattered bronchi on lung auscultation. The child also experienced vomiting and diarrhea. Okay, so this is clearly what we see, a classical picture of influenza-like illness in pediatric population with high-grade fever, with respiratory involvement and some GI involvement also. Because this is high grade fever, cough and some lethargy, we will categorize this as a category B. Is this influenza infection? Yes, definitely. This is influenza like illness. This comes in category B and we should initiate treatment. What is category B? As we already seen, fever, patient with high grade fever, severe sore throat, and they require home isolation and oseltamivir. Also, category A patients with high risk predisposing factors also comes in category B. Okay, so antiviral should be started as early as possible. If possible, the testing can be done, but don't wait for testing to start oseltamivir. Then case 2, a previously healthy 8-year-old boy was brought to our institute with moderate fever, cough and occipital headache since 5 days and one episode of generalized tonic-clonic convulsion associated with fever just before admission. Immediately after admission, he developed right-sided focal convulsions, which were controlled with IV midazolam. On admission, a febrile, BP stable, heart rate 82, respiratory rate 24, saturation 97 on room air, BSL 96, GCS was 10 by 15, somewhat low, and pupils were equal and reacting, and mild terminal neck stiffness. So depending on these clinical features and presentation, we suspected CNS involvement with fever, some encephalitis-like picture. So we did routine hemogram, blood gas and electrolytes, they were all normal. We sent the patient for CT and it showed hypodensity in the subcortical white matter in the posterior parietal lobes, suggestive of encephalitis. We did lumbar puncture and it showed 40 cells, proteins were 48 milligram, glucose was 71 milligram, and no organism seen on gram stain. So over and all, the picture clinically and on investigation, we found this this to be a patient of viral encephalitis. Now, the chest X-ray revealed a small focal consolidation in the right lower zone. So we have a patient with viral encephalitis with some respiratory involvement. So along with other viruses or which other common viruses which causes viral encephalitis, in such patients, we should also keep in mind that influenza virus may present as a CNS case also. So that also should be kept in mind. So this is patient falling into category C as he is having convulsions and some low GCS. So we admitted and started with uh, supportive management and the testing was done and we started him with antiviral antibiotic combination. Nasopharyngeal aspirate specimen was tested and came positive for H1N1. We sent CSF also for H1N1 by RT-PCR, but it was negative. We sent CSF PCR herpes simplex virus because which is the common cause of viral encephalitis. We had to send other viruses also as a biofire, but because patient was not affording, we could not send that. And but because we have H1N1 positive with some lung involvement, with CNS involvement, and the patient came during influenza season, like in rainy season, so we suspected this to be influenza virus associated encephalitis. And as we already started with broad spectrum IV antibiotic or oseltamivir and acyclovir treatment, EEG showed evidence of focal slowing and sharp activities from the left central parietal region. We actually HSV PCR, herpes simplex virus PCR was initially negative. We repeated for CSF after 48 hours, repeat HSV PCR also negative. So with this treatment, the sensory improved within 48 hours, and there were no further seizures. So we omitted acyclovir. We continued with oseltamivir for 5 days, and the child was discharged after 10 days of hospitalization. So the point which we want to highlight here, that influenza virus can present as a severe complications also, because sir has noted, if you remember, he has shown a one slide in which there are different complications of influenza virus he had shown, and CNS encephalitis is one of the complications how the child can present to us. So we should keep that in mind also. Again, with along with this, I just wanted to mention one case. There was a twin siblings who came to us on day 5th of fever, high grade fever, cough and cold. Initially on day 1 or 2, he had shown to local general practitioner, who had given him some antibiotic for upper respiratory tract infection and symptomatic treatment. But because the child's complaint continued, they came to us on day 5th of illness. And but meanwhile, we actually started treatment on both those kids, and the kids improved. But what the thing happened, that because of the illness, the grandparents had came to their home to visit those kids, and they have been already exposed. And the one of the grandparent got sick. He got lower respiratory tract infection. He got viral pneumonia. He was admitted. He was intubated, and bronchoalveolar lavage was sent, and it came positive for H1N1. So the point is that these kids these kids got this infection, and they transmitted their infection to the high risk contacts like elderlies. Okay, so this could have been prevented if the kids would have been started early, oseltamivir, and home isolation or separation would have been practiced, or chemoprophylaxis for high risk contacts would have been given. So we have to keep these things also in mind. So these are the cases which I wanted to present. I thank Hetero. I thank all the officials associated with this. And thank you very much for giving us the time and opportunity for this presentation. Thank you very much.
Thank you, sir. Thanks for your insights, especially
Thank you.
insights in the disease passing on to the grandparents. I mean, it's very interesting. The virus is so,
Yes.
thanks everyone. Thanks all the doctors who took time from their schedule and attended this meeting. Thank you, field peer personnel and marketing personnel at Hitro for conceptualizing.
Unmute come.
Once again, thanks Dr. Mahajan and Dr. Kedare. And signing off. Thanks,
Thank you.
IT team. Thank you.
Thank you, Hetero team, again.
Thank you, sir.
Thank you.
Giving us a good package.
Thank you, sir. Thanks, Revali.
Academic platform to
Thanks, doctor.
Thanks.
discuss
Okay, sir. पाऊस आहे का तुमच्या इकडे?
and interact with each other.